Hello, everybody, and welcome. We're so happy to have you all with us for today's presentation. My name is Mariah Blake, and I'm the Program Manager here at the Association of Clinicians for the Underserved. Today's program, Suicide Prevention in Primary Care, a toolkit for primary care provider teams, will be presented by Dr. Virna Little and Dr. Ursula Whiteside. I just have a few quick things to go over before we let our presenters take it away. ACU is a national nonprofit focused on the recruitment and retention of clinicians in underserved areas. We do that through projects like our Star Center Workforce Project, National Health Service Corps Advocacy, and training and resources for clinicians of all disciplines. Supporting all of you doing this great work is part of what brought us to this webinar, and we hope we at ECU can be more reliable or be a reliable learning source for our members and all clinicians and their teams providing care to vulnerable populations. We're always striving to improve care for our underserved communities, and we hope that this webinar will provide you with some resources to strengthen your organization's ability to provide effective and meaningful care. I'm joined on the line today by Craig Kennedy, ACU's Executive Director. Allison Albuseca, our Vice President for Training and Programs, also backs up our programming work here. Like I said, my name is Mariah Blake. I'm the Program Manager here, and my contact information is on the slide right there. The ACU team will be keeping an eye on our questions throughout today's session. Feel free to pop those into the questions or chat box on the right side of your screen, and we'll try and direct you to the correct person for that question. If you have any technical issues during today's presentation, feel free to put any notes into the chat box or email me at mblake@clinicians.org, and I'll do my best to help you out. This webinar was developed in partnership with Centene. I'll now hand the mic over to Craig Kennedy, who would like to say a few words about our partnership with Centene.
Thank you, Mariah. This is Craig Kennedy with ACU. I'm the Executive Director, and thank you everybody for joining us today. Very much appreciate your time on this Monday, and especially appreciate our presenters, Dr. Whiteside and Dr. Little, for their expertise throughout the process. I do want to say thank you to Centene Corporation, our partner in this activity. They have not just for this webinar, but trainings across the country. We've developed a toolkit with them. We're going to be doing podcasts and blogs and web postings and updating our clinical information on our website in partnership with Centene, and we very much appreciate their support. In particular, Joyce Larkin and Marianne Burdison have been very supportive at Centene, and we'd just like to say thank you to them for their strong support for us engaging in this topic and helping clinicians across the country engage in this timely manner. Thank you very much, and thank you for the presenters, and thank you, Mariah, for setting it all up for us.
All right, thank you very much, Craig. All right, Ms. I've just got a little bit of housekeeping to go over with everybody here. We are recording today's webinar. We'll send an email with a follow-up link to the recording of this session and a copy of the slides for you to review. We'll also be sending a link to a post-session survey that we hope you'll all fill out as well. We hope that everyone will ask questions. Like I said, pop those into the questions box throughout the presentation, and we'll do our best to address those as we go. We'll reserve a couple of minutes at the very end of the session for some actual Q&A, but we can handle that there as well. But just feel free to send those questions on in. And as always, here at ACU, we hope you will have a little fun with our presentation, communicating with the presenting team. One more note, we have submitted an application to the American Academy for Family Physicians to award 1.5 CME credits for today's webinar. Pending approval from AAFP, we will be sending an e-certificate acknowledging the credit awarded to any attendee who completes the pre- and post-session surveys. So we've put the link to the pre-session survey in the chat box there. If you could fill that out and then fill out the post-session survey when that is sent out by email, and we'll be able to track your participation today for that credit. If you have any questions at all about that, feel free to email me at mblake@clinicians.org. Okay. And now our presenting team. We're excited to be joined today by Dr. Virna Little, Director of the Center for Innovation in Mental Health at CME University of New York School of Public Health, and Dr. Ursula Whiteside, a licensed clinical psychologist CEO of nowmattersnow.org, and clinical faculty at the University of Washington. I know we have a lot to cover here today, so I'll hand things over quickly to our presenters to further introduce themselves, and we can get started. Thank you again for joining us, and thank you again to our presenters.
Thank you very much, and thank you so much for Mariah and Craig for giving us such a wonderful kickoff. Again, we appreciate everyone's time today. Both myself and Ursula are very excited to be here. And again, thank you to Centene. And if you look in your handout section for the webinar, you will see a Suicide Safer Care guide that is available to all of you to have electronically or to print out. It was really meant to be a guide to support today's webinar, but also to give you tools and information that you can use during patient care and in the field. So again, please make sure that you get a copy of that. I think you'll find it helpful as well. So good afternoon again. Thank you for your time. My name is Virna. I am affiliated with ACU as the board chair, as well as with the Center of Innovation in Mental Health. And what we're really hoping to do today, both myself and Dr. Whiteside, is to give very clear information about what practices can do for suicide safer care. So I'm going to ask folks to mute yourself if you're not speaking, just because I'm getting a bit of an echo. And Dr. Whiteside, I'm going to let you introduce yourself, and then we'll get started.
Great. Good morning / afternoon, everybody. I'm out in Seattle, so happy to be on the call with you. As Dr. Lynn, or Virna, as I like to call her, said, in the handout section, there is a PDF that's called Suicide Safer Care. And a lot of work went into that to provide very practical information that you can pull out and use immediately. It's not one of those reference materials that's too bulky or too many words. It's very practical. So please make sure you make use of that. Open it now, take a look at it. I think you'll find it of value. One of the ways that we like to set the stage for this type of webinar is to communicate how common the suicidal experience is. For a long time, we really thought about people who were suicidal as those people over there, those people who are having that experience. And I would say I'm as guilty of that as anybody. What we're learning over time is that the number of people who have suicidal thoughts is quite large. In fact, it may be 4% of Americans, or almost 10 million Americans, that seriously consider suicide in a given year. And while that means there's an enormous amount of suffering, that also means that there's good news in that the vast majority of people who seriously consider suicide in a given year, we estimate that less than 0.5% will go on to die by suicide. And we think that that's important because as you're sitting with that suicidal person in your office, we want to give you permission to really be present with them, as opposed to sort of panicking about whether they need to be hospitalized or not, but to be in the moment. And you'll hear about why that is so important for the person who's had suicidal experiences, why they say that above all else is the most important thing. We're also setting the stage by communicating about language, because language communicates not only to other people, but to ourselves. And the type of language we use to talk about people who've been suicidal or who are suicidal makes a difference in their care, and makes it in large part because it impacts their experience. So we're moving away from language that implies that we know someone's intent, so that we know that their behavior was manipulative or attention-seeking, or it was a cry for help. We're moving away from language that implies we know what the person's intent was, to language that is descriptive in the same way that you would describe any other behavior in the medical record. That allows us to communicate more clearly between each other as providers, but it also impacts the way that we sit with patients when we're having a conversation with them about that suicide attempt, or about that situation where they called 4 times, said they were going to take an overdose, hung up, and said, you haven't been a good provider to me. What you would do is you would describe that behavior in the electronic health record, as opposed to say that the person made a cry for help. We're using person-first language, such as diagnosed with borderline personality versus a borderline. And we're talking about working with our clients as opposed to dealing with them and our patients. These things are what we're finding are things that suicidal people are asking for. And those people, people including myself, are saying this type of language matters. Please change the way that you're talking about things. Move away from committed, which sounds like a crime, and move more towards being more descriptive, more compassionate and accurate.
So one of the things that we're going to do today is we're going to talk about the primary care provider role in suicide safer care. So primary care providers and their teams. And we've been very fortunate through this project to be able to go around the country talking to primary care providers and their teams, and actually with this webinar have reached about 1,000 people across the country that have been trained. So we're very excited about that. And one of the things that we keep hearing is that, yes, we really do want to participate in suicide safer care. We want to help identify people that might be at risk that we're caring for in our practice. We want to be able to know what to do. We want to do some safety planning. And most importantly, what can we really do during the course of a primary care visit? So those are all things that we're going to get an opportunity to talk about today. So one of the things that inspired the writing of the guidebook and this project, this is really a call to action for primary care providers. One of the things that people are in agreement around the country as we see the suicide rates rise in the communities around the country is that we're not going to be able to change that dynamic until we really engage primary care and really think about what happens during a primary care session. Go ahead. And one of the things we know is that many of the patients who die by suicide saw their primary care provider in the year before their death. In fact, many of them saw the primary care provider in the month before their death, particularly seniors. And this is really important information because what we know is that many people who die by suicide are not connected to mental health services. And in fact, many of them may not have a mental health diagnosis at the time of death. Many people had an emergency room visit. And so what we know is that we have an opportunity in primary care to really ask people about suicide, identify people who are at risk, and ultimately save lives. So often what we hear a lot of times as we go is that, you know what, the minute somebody says that they're suicidal, I refer them to behavioral health. And that's really helpful and certainly something that many practices do. However, sometimes we don't always think about that patient coming back. So if I get identified in a primary care visit as being at risk for suicide and referred for mental health services, and maybe I'm engaged in behavioral health services, I'm still coming back to primary care for my diabetes and my ear infection. And so what do we do different during those visits? So sometimes we only think about the time that we're caring for people when they're identified as opposed to their ongoing primary care. And those are really two different populations. And so also thinking about with such a short amount of time, I don't have time to ask this. I only get 15 minutes if I'm lucky. I have a full day of patients. I don't have time to ask. And I often tell the story about bringing my husband in for a visit to primary care. And he came in actually because he was having trouble with his hearing, and they took his pressure. And the medical assistant made kind of a face, and then she left the room, and the primary care provider came in and took his pressure and started to ask him questions because it had been identified through the intake and screening process that his pressure was very, very high. So the primary care provider started to ask him questions, a little bit of history. Has something been going on in his life that was very stressful? Had he ever taken any medication? Started to think about a plan. Maybe he might need to go, to the emergency room. They were going to, keep him for a little bit and check his pressure in a couple of minutes. And so what happened is we came in for one thing, and because his life and safety was at risk, really switched gears to address what was the primary presenting problem to his health and safety. We do that all day long in primary care. We shift gears when people are at risk. And so really thinking about it is the same. If I come in and I say that I'm at risk for suicide, we need to stop and we need to address what's the primary risk for that patient, get some information, and have some basic interventions just like we do all day long. And so really thinking about it a little bit differently. And what we know about having the knowledge to assess or intervene is what saves lives, is giving people hope. And we are all capable, regardless of our licensure or background, to be able to give someone hope. And so really thinking about suicide safer care is part of what you do in primary care, having the ability to do so and folding it in with your other initiatives that are going on. And we can talk a little bit more about that as well. Go ahead. One of the things that you're going to start to see is that some of the regulatory organizations are starting to really require that people have a plan and practices have a plan in place for addressing patients at risk for suicide. This is one that was issued by the Joint Commission, but we know that CARF is issued information as well, as are some others. So this is something that you're going to see. This is the Joint Commission Sentinel Alert 56. So for any of you who are Joint Commissioned, to really look at this and maybe even use it as a catalyst to be able to sit down and put some plans in place for people you might identify who are at risk for suicide. Go ahead. One of the things that we always like to talk to practices about is kind of the holes in your Swiss cheese, right? The places that people at risk for suicide could potentially fall through the cracks. So many of us, this is not the fault of a clinician or a provider or nursing or anyone. This is really thinking about places in your system or your practice or your organization where people who are at risk might get lost for care. And I always like to think about it as like wrapping a warm fuzzy blanket around people who are at risk. And some of the common places and practices that people fall through the holes in your cheese, or you have some drafts in your warm fuzzy blanket, are, for example, maybe I see someone in primary care, they express that they're at risk for suicide, I refer them for mental health, they come back 2 weeks later, but we don't have a system in place so that I know that you were at risk for suicide, or I remember, or it's marked for me to ask whether or not you're engaged in behavioral health services. So maybe you didn't get there and we don't have a way to really know that. Maybe we don't have a way to know that if you're at risk for suicide and you cancel an appointment, we do something different. So really thinking about ways that you're able to block the holes in your Swiss cheese are really going to be helpful. And this is an ongoing process, just like we're always learning how to care for our diabetics better. We're always learning how to care for our people at risk for suicide better, and our patient population as a whole, right? The minute we start asking about how can we do what we do better, then we've lost our edge. Go ahead. I encourage all of you to go to the zerosuicide.com website. It's enormously helpful. There's tools and trainings on there for clinicians that give CMEs and CEUs. There's some of the trainings on the tools that we're going to reference today. It also has some videos and information that you might find helpful if you wanted to do a little more of this work in your organization. So I encourage you all to visit that website.
I want to add on to what Virna was saying about our responsibility and role in primary care. As we've been working in the suicide prevention field for many, many years, what we're finding is that we realize if we're going to move the dial on suicide, it's going to have to be through primary care. Males die by suicide at a far higher rate than females. And are far less likely to seek out mental health care. In fact, suicide is the 4th leading cause of death among men ages 45 to 54. And at the same time, those men are showing up in our primary care offices, and there is this enormous opportunity there to identify who's at risk. So back to this slide. At the end of the day, when Virna and I go out and do trainings, what people with lived experience ask us to do is to make sure we communicate these three things. That all the rest that we're telling you is very important, but make sure that your providers that you're training know these three things. People who are suicidal, who have been suicidal, want you to know these three things. That really what's most important in an interaction and what's most therapeutic, or in contrary, not therapeutic, would be if you were to be calm in that interaction. That would be a therapeutic interaction, meaning you are not panicking, you are not immediately jumping out of the room to go find behavioral health. You're also being present and listening and reflecting. So you are coming back into your body, remembering that it's very unlikely that this person sitting with you is suicidal, and remembering that what we're hearing from people who are suicidal is that being present with them is an intervention in itself. So we tend to think, wow, suicide's super complex. I have to refer them to specialty behavioral health. But what suicidal people are saying is someone sitting with me for 3 minutes and being present and showing compassion makes a huge difference. So first of all, not panicking. Second of all, being present. And third of all, providing some hope. And that hope, what we mean is to provide a simple phrase that is something like, you know, based on what I see in your electronic health record, you've been through some really hard times. That makes me have hope for you to get through this. That could mean, I liked meeting with you. I hope you'll come back. I want to set an appointment for 2 weeks. Just given what you're going through, I'd like us to meet a little bit more frequently. Showing that you like them, showing that you see their strength, those two things tend to be very powerful. When somebody's suicidal, it's often because things are not going well in their life. And so there are often very few people who like them at that moment, who interact positively with them. And this is an opportunity for you to show that this is a person that you're glad that they're there. You look forward to them coming back. I'm not telling you to do something that's not genuine, but know that that is a powerful intervention in itself for somebody who's going through their day-to-day life, oftentimes not being liked because they don't feel very good. Of course, also referring back to the first slide where we talked about language and how that makes an impact on how people feel as well. Virna, you might be on mute.
Yes, sorry. So one of the things we know is that many of you are screening for depression. So right now, someone comes into your office, they're probably asked the PHQ-2, some questions about feeling sad or hopeless. So all of you now are directly, because of suicide or because of the PHQ-9, asking about suicide in the 9th question, patients who would express thoughts of being better off dead. And what we know is that patients who answer yes to that question are more likely to die by suicide. One of the things we're also seeing is, or realizing, is that it's really important to ask patients directly about suicide risks. So many organizations are now switching to what's called the PHQ-3, which are those first 2 questions, and then the 3rd question being question 9. So asking people about being sad or hopeless, and then asking them very directly about their thoughts about suicide. We also know that social determinants play a role. So Ursula was just talking about suicide being the leading cause of death for men. One of the things that I did one time in practice that I was working with is we took patients, men who were ages 45 to 62, who had screened negative for depression, were not in mental health services, but had been more than 2 social determinants. And we actually asked them about suicide, and about 10% of them scored positive. And so really thinking about the role that social determinants play. So with a patient who's talking about losing their job, financial stressors, relationship problems, employment problems, they are someone who is potentially at risk for suicide. Not all patients have a diagnosis of depression. We know that alcohol and substance use plays a role, and we certainly know that transitions are a time of risk. And many times people think, well, it's just a transition from a psychiatric hospitalization, and don't know that patients getting discharged from a medical hospitalization are actually just as at risk for suicide. Same with physical rehab, substance abuse rehab, incarceration. Transitions are a very high time of risk for people. And so if you have a patient who's transitioning from one of those places, maybe ask them directly or put a system in place. So many organizations now have someone from the primary care team who calls patients that are in the hospital or getting discharged or have just been discharged as part of a transitions of care. So maybe to start to ask those patients the PHQ-9 or to ask them directly about suicide would be a place that you might be able to incorporate that into your workflows. And it's really important that all of you know how many patients in your practice are or on your panels are at risk. One of the things that we really encourage providers to do, and there's some information in the guide, is to add suicide risk to your problem list. That way you know when someone comes back in and you remember to ask them. You know how many patients in your practice are at risk, and it's apparent. So if you go on vacation and I maybe see your patient, then I know to ask that patient or to talk to that patient or do something different in that session around medications if I know that patient is at risk for suicide. So again, most of you are familiar with the PHQ-9. This is certainly a tool that most primary care practices are using at this point. And again, question 9 is the question about suicide. And so one of the things that it's really important to do is to talk to patients about all of their symptoms. And Ursula, I'll turn it over to you.
Yeah, I wanted to, I love the PHQ-9. I don't know that there's many people who say that, but I really love it because what we found is that this tool can be used as a screener for who's at greatest risk for suicide and suicide attempt. So just a little background, Virna was mentioning earlier, there's a tool that we're calling the PHQ-3. And that is because it includes item 1, 2, and 9. We just came from a tribal health system who's been using this in their primary care, and they're finding it very useful. And the reason why to add that 9th item is because independent of all the other items, that question predicts suicide and suicide attempt. So I got to be an author on a paper that looked at over 100,000 PHQs, and what we found is that for people who say those farthest 2 categories, more than half the days or nearly every day, for people who scored that way on thoughts that you would be better off dead or hurting yourself in some way, those folks are at 5 times greater risk of suicide death and 7 to 9 times greater risk of suicide attempt, meaning that we can use this as a tool to identify who should we be following up with, to do something called safety planning, to do a deeper dive into how suicidal they are. We'll talk about that in a moment. You can use this tool in that way. And that item is as predictive or better as cholesterol scores are of cardiac event. So you can feel confident in using this as a way to identify people who are most at risk. And going back to what we said earlier about suicide being the 10th leading cause of death overall, and then 4th leading cause of death for middle-aged males. I mean, you guys are in such an excellent position because your patients trust you. There isn't the stigma associated with mental health, you know, as external carve-out behavioral health that there is with primary care. I mean, you really have the potential to be the future on this, and very brief interventions can make an enormous difference. That's what we're finding. So I always run into this issue where as soon as things start becoming difficult, they just immediately suggest that I go to the mental hospital. And I just cannot stress enough that it was not a good environment for me. And they still suggest that I go back when I know it'll make things worse. It just seems like it's one of their first options when it should be a last resort. The data actually supports this. There's no evidence to suggest that psychiatric hospitalization is beneficial to those who are suicidal. What we know is that for people who are acutely suicidal and there's no alternative or less restrictive method, then that would make sense. But in large part, inpatient psychiatric care is not necessarily recommended, and that we manage most of this care outside of the inpatient psychiatric hospitalization unit. And we will give you a tool in a moment to help determine that, a series of 5 yes or no questions to help you decide, do I need to do further evaluation for an inpatient psychiatric unit, or for this person who's first identifying with suicidal thoughts, can I set up an appointment in a week and leave them a voicemail in a few days? What can I do in the meantime? What we're finding is that most people's suicide ideation can be managed outpatient. Can you imagine if, those people that had seriously considered suicide, nearly 10 million of them, if we'd hospitalized all of them, first of all, there would never ever have been enough room. It would be impossible, right? And second of all, it wouldn't have been good care. What we find is oftentimes people are sent to the emergency room, and there's this missed opportunity to have a few minutes spent developing a plan for managing those suicidal thoughts. Often relationships are disrupted when people are sent to the emergency room. They feel like they can no longer trust their primary care provider because oftentimes they're sent home from there without having any help. It is fairly difficult to be hospitalized, psychiatrically hospitalized, and it's not necessarily helpful. There's even some evidence to suggest that it may be harmful.
So when we talk about assessing risk, this does happen in primary care settings. And more, what we're seeing is that providers and their teams are becoming more comfortable. And one of the things that I like to talk about is, before we started using tools like the PHQ-9, I'm a psychologist and a social worker by trade, and I've practiced in primary care settings. And many times I would get a referral from someone and they would say, this patient is really depressed. But when I would talk to them, they weren't that depressed. Or I would have a hard time communicating to primary care how worried or depressed someone was or how worried I was about them. And then when the PHQ-9 came along, if I say that, Craig scored a 27 on the PHQ-9, everybody on this webinar knows what that means. It means the same to all of us, regardless of our discipline. We all go, oh, right? And so one of the things that's really important about the tool that we're going to talk about is that it's important that everybody talk the same language about assessment. So you might say, listen, I don't know if I'm going to use this tool in my practice, but it's really important to know about the tool and understand what an assessment is and what happens so that you know all of those pieces. So again, really important that we all talk the same language. And again, this is the primary care visit. So if I come in, then this is where we spend our time talking about my risk for suicide, because that's what is the primary presenting issue. Go ahead. So the Columbia scale is a very short tool. There's actually two versions, but we will show you what's now affectionately called the primary care version. It's a lot of questions, actually, or questions that you probably intuitively already ask your patients who expressed risk for suicide, and it really helps you determine someone's risk and the immediacy of that risk. So really helping you to plan for that patient. So when we talked about, the level of risk from my husband's pressure, this is really the same principle around suicide risk. So the nice thing about the Columbia scale is that it's very simple, that you're able to ask the question in only a few minutes, right? And you don't have to be trained. People of all disciplines or without licensure have and do administer the Columbia scale, right? It really helps us decide what to do so that we can really appropriately determine who needs what resources. And again, it's universal. This is actually built into many of the electronic health records. People now in emergency rooms are expecting to get it if someone does need a higher level of care. And so really using this tool sort of broadly. And Ursula, I don't know if you wanted to add.
Yeah, I just wanted to add that what Virna and I have been talking about are the new recommended standard care guidelines. So the Joint Commission supports what we're talking about. New national guidelines from the National Action Alliance for Suicide Prevention make these recommendations, and they are intended to be done in a very brief period of time to support your work and move as quickly as possible to making a plan or problem solving what to do next once somebody's identified with suicide ideation. These approaches are supported by, we mentioned Zero Suicide earlier in the Joint Commission, but also by the CDC the NIH, and SAMHSA, Substance Abuse and Mental Health Administration, are all on board with care guidelines that include screening with a tool like the PHQ, assessment with a tool like the Columbia, like we're going over, and then 2 additional interventions, which are called safety planning and caring context, which we'll get to shortly. Go ahead, Virna.
So one of the things about this is free. So the training is available online. We're going to give you the link. The link is in the book. It's also on the Zero Suicide website. You can go take this training. It's really nice because primary care providers and their teams can get trained free of charge, and everyone can have the same training. And it really helps us be consistent in terms of our language and assessing people at risk. Very non-judgmental, and really avoids using language that is upsetting or stigmatizing or not consistent with some of the things that we've been talking about today.
So this is what the questions look like. I want to go back for a moment to the PHQ. You've got somebody here who says they're having thoughts that they would be better off dead or hurting themselves in some way, and then they say they're having those more than half the days or nearly every. How you would transition from the screening tool to an assessment tool would be something like this. So they come into your office and they're there for a diabetes visit, but they have been asked to fill out the full PHQ, maybe because they had previous depression, I'm not sure. But you're scanning their PHQ and you're using this to help guide that time that you have with that patient. So you say, I see that you've been having trouble sleeping, and also that you've had some impact on your appetite. I want to make sure we talk about those in context of your diabetes, and then also maybe in context to this last question here. I see that you've been having thoughts that you'd be better off dead or hurting yourself in some way more than half the days over the last few weeks. Thank you so much for telling me that. I really appreciate that. At our clinic, we think that talking about suicide is really important. So what I'm going to do next is ask you a few yes or no questions. I'm not going to ask you for all the details now, but I want to get a sense of where you're at. And I also want you to know that suicidal thoughts are not that uncommon. Many people who are experiencing depression or having a hard time often have these experiences. So I'm going to go ahead and ask you this question. Can you answer yes or no whether or not you've had any actual thoughts of killing yourself? You have. Okay. And have you been thinking about how you might kill yourself, how you might do that? You have. Okay, thanks for letting me know. Have you had any of these thoughts and had some intention of acting on them? You're not sure? Okay, well, why don't we talk a little bit more about that? Okay, so I'm gonna pause that role modeling there. What I did was I asked these yes or no questions. I'd given that person a heads up that the yes or no questions were coming and that I wasn't gonna be diving into the details. So this avoids you going into the details of something before you've gotten to what's the most risky thing going on. And you stop when you get a no on this question. Essentially, what you're trying to do with this assessment is figure out, okay, is this person having suicidal thoughts in the sense that they wake up and wish that they didn't have to go to work and they wish they weren't around, or is it that they have a gun in the car and they're desperate inside but don't know how to ask for help? You're trying to really get at this. And this person said, I don't know about have you had any thoughts and had some intention on acting on them. That's where I would say, tell me more about what you mean and try and understand what was going on there. You see that these questions go in order of increasing severity. So have you been thinking about how you might do this? To have you had any thoughts and had some intention of acting on them? To have you started to work out a plan or the details of how to kill yourself? Do you tend to carry out this plan? We find that when people are in this fifth question, when they're in that category, their risk increases quite a bit. When people have a detailed plan, that's when the bets are off. This is when we are shifting our focus. This is when the person's having potentially an acute cardiac event in your office, and everything else needs to go out the window and focus on figuring out what's exactly going on. And this is when you should be paying more attention rather than leaving the room and trying to find someone who can help them in that situation. This is when you should be really present with that person. Here are some suggestions about how you would go about determining level of care based on the responses you got on these questions. If they're having some transient thoughts of suicide, and you notice I skipped question 1, that's because that's similar to item 9. This is when you make sure you had a scheduled follow-up, and that you knew what to do if they didn't show, or your staff knew if they don't show, or if they cancel, we want to make sure we follow up with them. And then you get into a higher level of care, that if they're saying they've been thinking about how they might do it and had some intention, you're addressing lethal means, and you're doing something called safety planning, which we'll talk about in a moment. You're making sure that they have a follow-up appointment. Like, you're not letting go of that relationship, because that's even more important now that they're more suicidal. And then the last would be, having them be prepared to harm themselves. That's when you're evaluating hospitalization. You're always addressing lethal means in this case. You're doing something called safety planning, and you're always scheduling a follow-up. Even if they're going to go to the emergency room, even if you're sending them to the emergency room, you still want to work on safety planning, get started on it. You still want to schedule a follow-up with them. There's a training that is located here. You can also go to zerosuicide.com and search for Columbia training. But this is a good overview. Virna, what else do you want to add?
I don't think I have anything else to add at the moment.
Okay. Earlier I mentioned the recommended standard of care, which is supported by the Zero Suicide Initiative, which is supported by the CDC, the NIH, and SAMHSA. That is screening and assessment, which in this case was the PHQ in Columbia, and then safety planning, and then caring context. So now safety planning, it's an intervention that consists of a written prioritized list of coping strategies and sources of support that patients can use to alleviate suicidal crisis. So really, and this is a very important point that could change the way you think about suicide altogether, our job is not to prevent suicidal thoughts. That's really not, that is not something we have control of. What our job is to do is to help people have more resources to manage those suicidal thoughts. And that's where a safety plan comes in. We're helping people have the tools to manage suicidal thoughts. And there are a number of different types of safety plans, but at the bare minimum, what you want to do for safety planning is to have them put the suicide prevention lifeline and the crisis text line in their phone. So why don't you take out your phone right now and enter these two numbers, because if you have it in your phone, you're far more likely to use it than if you've been told about it and told to look it up. So if I'm sitting with a patient and I've identified that they are having some thoughts and they've been thinking about how they might do that, I'm going to say, hey, there's something I want you to do right away. And I want you to have this resource in your phone should you or someone else need it. Take out your phone and put this number in. It's 1-800. Got your phone out? Okay. 273-8255. You got it? Okay, great. So you call this number, you'll be connected with somebody who's trained to talk about suicide. And you can just call if you have questions. A family member of yours can call. This line is open for anyone. This other one is the crisis text line. And some people prefer text messaging to reach out for support. It's 741-741. And you can send any message to this to say hello, hi, it will start a conversation. If I've got a teen in my office and they say, I would never use this, I say, okay, great, why don't we try it out right now so you see what it's like. The more down the path you get of having someone do something for their crisis plan, the more likely they are to do it when they leave. So I always try and get people to initiate the crisis text line, the suicide prevention lifeline. If I can, I might ask them to do that as I step out of the room to do something else. I might ask them to just call and try it out. Just tell them to tell the person who answers they're just trying it out because their provider asked them to do it. But anyway, you want them to have this resource in their phone. Also, you want to address guns and their preferred method for suicide. So this is the person who's saying, yeah, I've been thinking about how I might do it. This is where you're asking. And this is where you lose control over how much time that this session will take, how much time this intervention will take, because they may not have a gun in the home, but they might have a gun in the home. They may not have a preferred method of suicide, or they might, and it might be the medications that they have in their home. So this is where it takes some time to address this if there's something going on, but where there's a lot of bang for your buck. There's very few things that we know prevent suicide. One is the zero suicide approach. Two is addressing access to lethal means. And the third is carrying contacts. You have the opportunity to provide a very powerful intervention. And in order for this to work, it's very helpful to add on at the end. Now, you said that you would store your pills besides your week's worth at your aunt's house. How will I know when you've done this? Because I want this to be a partnership. I want you to leave me a message at the end of the day letting me know that you've done this. But what do you think we should do if I don't hear from you? So we've added 2 pieces on, is to have them close the loop for you and to have them come up with an idea for what to do if you don't hear from them. We really find that closing the loop is incredibly important. So very quick and brief interventions are the Suicide Prevention Lifeline, and then this last one called a caring message. And you can download a caring message card from a resource called Now Matters Now, which we'll talk about. So Now Matters Now is a public resource, and this resource is associated with reductions in suicidal thoughts and negative emotions. So I'm the executive director, CEO of Now Matters Now. I'm completely a volunteer position, but this resource was developed for healthcare providers who didn't have tools to provide to their suicidal patients. And what we found is that, you saw that survey for a moment, but that people who visit this website have reductions in suicidal thoughts and negative emotions in a very short period of time. It includes videos. It's largely videos of people who've been suicidal, talking about how they use coping strategies from dialectical behavior therapy. Dialectical behavior therapy is the treatment with the most evidence for working with suicidal people. So this resource is there for you to use, and there are, in addition to the videos, and they're called DBT skills or coping strategies. In addition to these, there are also tools that are available under this More tab. There is something called, there are these safety plans here, and here's, you could download these for free and give them to your patient and have them fill them out on their own after you do those 3 steps we just mentioned. And that links to this website. There's also a guide for that safety plan, which is more intensive, where they can work their way through developing a safety plan, but have a guide to do that. That you're welcome to print out for your office. And then there's also example documentation. So there's some documents here that if you wanted to use to create a safety plan and document in your electronic health record, you could copy and paste this, and then the gray is what you would remove or change that would be specific to your intervention with them. So that resource is really built for providers, so that this resource Now Matters Now was built for providers so that they would have tools to support what they were doing. And then also there is this caring contact card, which you can send to Kinko's. Just email it to Kinko's and they can print for you, where you write a caring message, which we'll give you an example of in a moment. And then it has the website address on it as well. So those are resources for you to use and take advantage of. What's one thing that's unique about this safety plan is that it includes steps for what to do if you have an overwhelming urge to kill yourself. So it's essentially got a stop, drop, and roll for overwhelming suicidal crisis. And that's not something that's present in other safety plans. The standard safety plan that's used is called the Stanley and Brown. So this safety plan has been well validated. You can Google this Stanley, S-T-A-N-L-E-Y, and Brown. And this is the traditional safety plan. It includes place to identify your warning signs, your coping strategies, and really you can help somebody get started on this in your office and document that in your electronic health record.
And it's in your booklets as well.
Yeah. Go ahead, Virna.
So one of the things about safety planning, and just to talk a little bit about what Ursula was talking about, it's so important to have the Lifeline. in your phone to be able to pull out. I actually had a clinician the other day who said to me, every once in a while I need to find the cards and I never know where they are. And now I have it in my phone. It's so much easier. And then what I do is I have the patient program it in their phone, make the phone call. I step out and see another patient and then come back. So really building these things into your primary care, workflow and safety planning is one of them, right? And also, calling someone. So, if someone talks to me and I'm at risk for suicide and asks me who might be helpful, I say, well, Mariah is my person. She's the person that I would call if I was feeling unsafe. Then it's really important to call and talk to Mariah and say, listen, Virna has you listed on her safety plan, and so that you can talk to Mariah about being on the safety plan. Or maybe Mariah might say, listen, I would love to be on Virna's safety plan, but I don't have minutes for the entire month, or I can't pick up the phone, when I'm at work. And so then you can work to identify someone else. And to do safety planning and access to lethal means really means be creative. Walmart is on a lot of safety plans because it's open 24 hours a day where people can go and be with other people. It's accessible by public transportation. Using pictures, putting a picture of family members on a gun cabinet or on a gun box, or, on someone's dashboard. And so really talking to people about what would be helpful for them and keeping them safe.
One of the things that you're doing, if you're doing this well, if you're doing the recommended standard care, is you are doing that linkage between the screening to the assessment, where you're saying, thank you for saying yes about having suicidal thoughts. I appreciate you sharing that information. I'm going to ask you some yes or no questions. It's not uncommon that people have suicidal thoughts. You're doing that linkage, but then you're linking that to this safety plan or this crisis response plan, where you're saying a lot of what you're describing comes from a place of distress. What I'd like to do next is help you identify some things that you can do to cope during this period, because I want you to leave here having some new ideas. So I've got this piece of paper here. I'd like you to read over this, and I'm going to come back in a few minutes, and I'd like to talk to you more about it. In the meantime, be thinking about what might work for you. I don't want you to come up with anything that doesn't work, but what might actually work for you. So you're always weaving together these elements, this safety planning, this screening and assessment, and then this caring contacts. In terms of lethal means counseling, we put firearms first because almost 50% of suicides are by firearm. People attempt suicide using other methods, and often medications, people don't die by medications, but what people do die by are guns. And why it's so important to remove guns and preferred methods of suicide is that the research shows that if you have time and space between you and your preferred method for suicide or a gun, the chances that you'll kill yourself go down dramatically. And this is why we know that reducing access to lethal means works. We see it over and over again. In rural China, it was putting lock boxes on pesticides that were extremely lethal. In England, it was putting essentially acetaminophen in bubble packs where people stopped overdosing because they had enormous bottles of pills. It's been removing the type of gas from ovens. But what we know is when somebody doesn't have something in their environment, they're far less likely to attempt and die by suicide, just that time in that space. In fact, I just did a study that where we the headline for the paper is, I didn't wake up that day knowing I was going to die. So what we're finding is there's a large percent of people that they didn't plan ahead of time, but they had some suicidal thoughts. So if somebody's had some suicidal thoughts, making a plan for making their environment is very important. So always asking about guns, you want the bullets separated from the gun, you want them both locked up, and ideally you want them out of the house and for them to not have the combination. You emphasize that it's temporary. You do it in a matter-of-fact way. Like, really, this is what we do with everybody. You want to communicate to them indirectly or directly that you're not singling them out. That this is the same as seatbelts. That this is the same as any other public health intervention. This is just what you do because we know it works. And that that this is a temporary thing. What else do you want to add there, Virna?
So I think it's really important in terms of how you talk to patients. So many times we talk to patients about, their medications, and it's something that we really need to pay attention to. But often asking patients, if you were going to die by suicide, or if you're feeling not safe, where would you get the medication? And then many times we say, well, my grandmother, she has bags of it, or my neighbor. And so that you can really work with that patient around keeping them safe and removing those medications. Talking a lot about involving family or friends. So certainly making sure that you're also talking to your pharmacy. The time to talk to your pharmacy about keeping people safe who are at risk for suicide is now. So that if you call and you ask them about dispensing lesser medications, or if you talk to them about whether or not they have boxes, or if you talk to them about whether or not they can individually wrap medications now, that's way more helpful than trying to have that conversation when someone might be at risk. Go ahead.
Yeah. I think too, wanting to add that reviewing the medical chart to see what medications that person has been prescribed in the last couple of years is definitely warranted. I have a colleague who reviews the suicide death cases in a rural health system, and oftentimes people, for their attempt or even for their death, use medications and they've been prescribed by their healthcare providers. And that's when it is really important to look at, have they been prescribed medications that are lethal or highly lethal? And even if in that case they haven't been talking about that, I think it's worthwhile to make a plan in that case, that they're not saying they're suicidal and also have lethal amounts of medications that has been prescribed by you or someone else, documented in the electronic health record. All right, we talked about addressing access to lethal means and getting time and space between someone and their preferred method of suicide as something that is known to prevent suicide. The other thing, and believe it or not, that prevents suicide are non-demanding expressions of support. So very brief messages that show someone that you like them, essentially. And this goes back to the earlier recommendations from people who've been suicidal, who say, don't panic, be present, and provide hope. This is that hope part where you're saying, I don't know you that well yet. I'm glad that you've told me a little bit about your life. I have lots of hope for you. I hope you'll come back and see us again. We talked about linking the safety plan to the screening and assessment by saying, I have some ideas for how to manage the pain that you're going through. Let's have you take a look at this and come up with some ideas, and we'll talk about it. Now you're linking at the end, you're wrapping up the time that you have with this person by saying, before you go, I want to give you something, because I don't know for you, but for many people, sometimes they feel really bad in the middle of the night. And I want you to remember that somebody likes you and cares about you. So I'm going to write you this note. So if you wouldn't mind holding on a moment, I'd really appreciate it. So you take a moment and you write this message to them on the after visit summary or a Now Matters Now card or whatever it is, and you hand it to them and you ask them to put it in their wallet. You have just created an intervention that will live on in perpetuity. Like, this is, that 20 seconds or 1 minute, whatever it takes you, is the gift that keeps on giving. And you tailor it to the person who's in front of you. Maybe if it's a guy and you're the guy physician, you're saying like, hey, I just want to write you a note to remind you that I'm looking forward to seeing you again. Just put it in your wallet. You may never look at it, but it's important to me to give it to you. That can go a long ways. For them to be able to carry that hope along with them. What you're seeing here is from the Now Matters Now website under the More tab. This is a poster that can be downloaded and sent to Kinko's and printed out to put on the wall in the break room, for example. These are all examples of caring messages that people have submitted, that people with lived experience have approved. So these are examples that you can use to come up with your own, but really know that it doesn't have to be complicated. It can just really be as simple as, I look forward to seeing you again, or boy, I see how strong you are, that kind of thing. Great. great. We sure have enjoyed having you here for the webinar today. You're welcome to send us questions if you have them in the chat box. You can direct them to myself or Virna.
Or Mariah, if there's some in the chat box and you want to let us know or send them to us, then we can read them out.
Wonderful. Thank you both for the presentation there. And just a reminder to everybody on the line, you can pop your questions if you have them right at the top of your head, and you can put them in the questions box and I'll read them out for you. If you come up with something later or you haven't quite got to that question just yet, feel free to email me at mblake@clinicians.org and I'll get you connected to the right person to answer your questions.
Thank you. So I'm showing you right now a poster that is put together by people with lived experience. When we say lived experience, sorry we didn't define that, that's people who've been suicidal. Things that they wish they would have known the first time they were suicidal. These you can put in your pocket to provide to your patients to say, you know, one thing that people who've been suicidal say they wish they would have known is that suicidal thoughts are their brain's way of trying to regulate emotions and extreme distress, like your brain's trying to tell you something. Or that there are things that can be done to help reduce those suicidal thoughts. So here are some ideas based on people who've been there, things they wish they would have known, which I think, you know, it's always valuable to anyone to know what others wish that they would have known in a situation we're in.
Thank you. So Ursula, one of the questions that I see here is whether or not some of these skills will work with adolescents.
Mm-hmm. I'm so glad you asked because I was not very confident that they would. But our latest survey data shows that adolescents are coming into this website more suicidal. This is, I think, over 1,000 adolescents coming in more suicidal and having greater drops in suicide ideation than adults. So I was surprised by this, but it looks like, I have not published this paper yet, but from the data and presenting it in Europe, it is very beneficial, or it looks like it is potentially beneficial for teens. They're having stronger reductions in suicidal thoughts than adults.
Great, thank you. And one other question here in the chat box is about the safety plan and how long safety plans might be good for. How often should you talk to patients about their safety plans?
Virna, you tell me what you think, but with a patient who's suicidal, it really only takes a minute to check in with them on it when you see them. If they've been saying more than half the days or nearly every day, I check in with them every time, especially in the primary care setting where you're not seeing them as often, to say, hey, has anything changed, or have you learned anything new that we should do to modify this? And that literally, that takes about 1 minute. And if there are changes, that is a session well spent for somebody who's identified as greater risk. I particularly for those who've said more than half the days or nearly every day on that 9th item, I would take that time to do it, because Virna will say this, it's a living document.
Right,
you know,
and like a care plan, yes.
Yeah. People will say, my warning sign is that I don't respond to messages. And then, you know, what happens over time is if you're on top of this, is that you get more specific about this. So eventually it would be, I know it's a warning sign for me if I haven't responded to my mom for over 3 days for her text message. So you're getting more specific about what the warning sign is in order to increase their awareness and catch themselves earlier. So every time you look at that safety plan, you're just putting the plan further up in their mind so that it may overcome the suicidal thoughts and the getting lost in the suicidal thoughts. You're just increasing the likelihood that they'll remember it because you put importance on it.
And one of the things that we're finding primary care offices are doing is that if someone comes in and they have suicide risk on their problem list, that someone on the team asks them about their safety plan, whether or not they have a copy and whether or not anything has changed. And so to really think about it that way. Mm-hmm. So Mariah, I don't know if there are other questions in the chat box that you wanted to read out.
Yeah, we've just had a couple come in, and just reminder to everybody as we're going through the questions, feel free to chime in with your own. But one question that just came in is, do you have a condensed version of these tools or other tools for working with people experiencing homelessness?
So generally, and we do work a lot with patients who are experiencing homelessness or health centers who have care for the homeless sites. And one of the things is that the safety planning often, what will happen is it gets condensed into something that they might be able to carry with them, a small version, or take a picture on the phone, or have a picture that's somewhere accessible to them. And so one of the things that we do, though, is that the safety planning really is going to look a lot different, but it may not be a shorter process, or the same with the Columbia scale. So we don't actually change the tool for the population.
Yeah, to add on what Virna says, it's great. People who use an index card. We have a colleague who does this for every safety plan, and they'll have the warning signs as like slept outside for three consecutive days, which means they're more vulnerable to suicidal thoughts, right? And haven't got a solid meal, for one day. These warning signs can be written right on the card. And then the internal coping strategies and the social settings may look very different for the homeless person. It may mean that they're sitting in a coffee shop where it's acceptable to sit. If that's one of their coping strategies in social settings. Internal coping strategy may be spending time in the library. So it's the same tools, but modified to make it easier to carry around.
Sure, thank you for that. We had another question come in. Do you have a toolkit for primary care organizations about writing agency policy for points with suicide, or patients, with suicidal ideation?
Yes, that actually is on the Zero Suicide website. There's some really good resources there to be able to use that in developing a pathway, writing protocols. So all of that information is on the Zero Suicide website, and I encourage all of you to visit that website for that.
Great, and we'll include that information in our follow-up email as well. Any of the resources that have been referenced while we've been going through, I'll include links so that y'all can access that pretty quickly.
Yes, and they're also all in the guidebook as well.
Fantastic. Another question came in. Is there a suicidal risk ICD-10 code to put on a problem list?
Yes, there is. They're in your guidebook as well, but yes, we really do encourage that. And there's a list of sort of what we would call a cheat sheet there.
That's under the handouts. I think both of the handouts are the same document, but that's a list of codes that you can use.
Great. And those handouts are available just now in the handouts portion of your GoToWebinar platform on your screen, and those will also be included in our follow-up email. All right. Well, I'm not seeing any
This is just showing you some of the pages. Yeah. Oh, no, that's okay. Just putting the guide up there so people can see a little bit what it looks like. Encourage you to look through it. I think you'll find it helpful. And also in many of the EMRs, if you start to type suicide, some of the codes will pop up as well. But they're all should be in there.
I know, I wish I knew it off the top of my head.
Yeah, that's okay. We'll have to look at that for next time, or maybe we'll put a slide in. So that's actually, people do ask that. So maybe we'll look at putting that in. If people have any questions or anything, please feel free to reach out to us. We're more than happy, to be a resource, reach out to Mariah. She can connect us or send you any additional information. We really appreciate people's time today on this important topic, and we hope you found it helpful and can leave and go and do some things in your primary care practice. So I want to personally thank you for your time today, and also ACU for hosting, and Centene for all of your support, and of course Ursula for all of her brilliance and expertise.
Thanks, everybody. We're so glad you're here. We hope that this gives you some practical tools that you can go and use right away. If you did, that would make my day all the more better. Month, year, that would be great. Thank you for your time.
And I'll remind you about the post-survey for the continuing education. So, Mariah, I'll turn it over to you to just finish up and give people that information.
Thank you. I was going to say, I think all the wrapping up points have been covered here for y'all. But thank you once again to our presenters, Dr. Little and Dr. Whiteside, for presenting on this topic. Thank you to everybody who joined us today and for submitting your questions. We will follow up with any of the questions that haven't quite been answered just yet, and we'll be sending out some follow-up information with a separate email. Just as a quick reminder, the slides from today's presentation are available for download. We'll send them out later, and I'll also be sending that post-survey that we would urge you all to fill out, especially if you would like to be awarded CME credit for today's session. Pending approval, we'll get that information out to you in the next little bit. And thank you all for joining us, and have a great rest of your day.
Thanks, everybody.